EM board bombs.
Welcome back to EM Board Bombs. We are back in action here. A couple week hiatus. Dr. Hussein is back with me. For those of you who don't remember, he is the co-founder and co-host, along with myself, for
There
EM
you go, co-founder,
Board
baby.
Bombs.
Let's do
Here
it.
at EM Board Bombs, of course, we give rapid information that you need for emergency medicine, for boards, and for life.
And for life.
Each episode is less than 15 minutes typically, unless we ramble sometimes, which I think is enjoyable.
Yeah,
Life is about
enjoy
that,
it.
right? Life is about
Hey,
that.
we're exhausted, but recovered finally, by the
Yes,
way. Can we
we've
say
had
that?
an
We do those
action-packed
board
few
blitz.
weeks.
Yeah, we do
Yes.
those board blitz
Yes.
episodes that are not the easiest to do.
No.
And then
No,
our
no.
premium subscribers got a couple extra board blitzes, and then they got videos, and they got other stuff. We had to take a little break, but we're back.
For sure. We are back in action here, ready for the next primetime season. You know, some people still have their boards coming up, but we have residents now that are starting to think about, hopefully, the ITE, the in-service training
There you
exam
go.
that's coming up in February. In fact, I've had a couple residents email me personally that are asking for information on the Rapid Bombs, and they're signing up already for Rapid Bombs subscription.
Yeah, you can find that on
Shout out to
EM.
some residents here at my program, UT, that have already done that. But
Love it. You can find EM Rapid Bombs. You just go to emboardbombs.com and then just click on the Question Bank podcast, and then you can access it there. That's our premium podcast where we drop hundreds and hundreds of episodes, and we drop episodes throughout the month as well. Keep updating that thing. That question bank keeps getting larger and larger. Hey, shout out to EM News, our only sponsor as well.
News.
emnews.com. Hey, just go there, check out some news. If you want to be old school, you can sign up for like a paper newsletter too. So you can be one of those like people on a flight and just like, push it out. You know, those people that just sit there on the planes with the paper,
I do that sometimes.
Yeah, just to don't even read, but
Yeah.
just to feel that paper.
Yeah.
I think a lot of the young ones listening right now probably don't know what that feels like or have seen a newspaper.
That's
or
definitely a
held one.
sign of wealth when you do that on the plane. You're like, whoa,
That's a flex, subtle
This-
flex.
this person must be in Wall
You and
Street.
I-
That's what I always
right.
thought growing up.
Except you and I are doing that in the back two rows of the of the plane.
Next to the lavatory. Yes,
There you
the lavatory seat.
Hey, you want to jump into this?
Yeah. It has less than $20, limited recline, but I'll take it.
but we
my-
are gonna have that paper.
Yeah, I only have so much CME money.
It's a do not bring that carry on because it is a basic economy flight.
For sure.
All right. So moving on, we have a 50-year-old female who presents to the emergency department after experiencing several episodes of palpitations and lightheadedness. She was in High Point on business. She was furniture shopping for her boutique in New York City that specializes in bespoke charcuterie boards that are connected to sofas. They are made specifically for garden parties. Her EKG shows polymorphic ventricular tachycardia. During the evaluation, the patient becomes altered and is no longer able to follow commands. Which of the following is the most appropriate initial steps in
I love this
management
question.
of this patient? I know this is might trip up
Such a
some
good
folks.
question.
Might trip up some people. So choice
I
A.
woke up this morning and I chose violence
This is so messed
with
up,
this question.
I'm going to let's see if people get this right. So A, is it intubation? B, is it amiodarone? C, magnesium sulfate? Or D, synchronized cardioversion? Correct answer here, Briggs, is what?
Correct answer here is choice D, synchronized cardioversion. I love this question. So here's what we did. We made you second guess yourself.
Yes.
Obviously, we gave away the patient has polymorphic ventricular tachycardia. Now, we'll get into some of the differences between what is polymorphic ventricular tachycardia, but many of you probably saw that term and thought, oh, that's torsades.
Yeah.
That's not an unreasonable assumption, right, to say
Not
that.
unreasonable. Nope.
And so when you say it's torsades, though, the answer that we're all trained to say in medical school is, oh, you give MAG, right? You give
Right.
MAG.
Right.
However, this patient is unstable. This patient is
Yes.
altered, not following commands. Of course, you're going to give magnesium sulfate. But the most immediate thing you should do for this patient right now in an unstable tachyarrhythmia, following your algorithm, is always to shock them. They still have pulses, and so you're doing synchronized cardioversion.
Can I just say that synchronized cardioversion, it's okay. Just do it.
I know, right? What is with, I think it's getting better. So I think
it
it's
is
getting better.
better.
No, it's getting
I think
better.
the
It's like
culture's getting better.
it's like IM epinephrine for anaphylaxis.
Yeah.
That was like in vogue for like several years too, and now it's like, okay, we can do that again.
We can do it again. Yeah.
I have to
it's
reassure residents every time we have to shock someone or like give IM epi, and like everyone looks around me like, "Are you sure you want to do that?"
yeah. It's like synchronize. In cardioversion too, it's like we're synchronizing.
Yeah, exactly.
It's going to be okay.
Like, you sure you just want to give amiodarone?
Anyways.
Yeah.
Let's get into this. Some more.
Cool. So torsades is a unique subset of polymorphic ventricular tachycardia, and it's characterized by that classic, twisting of the points pattern EKG. Everyone knows this. Everyone in med school learned this. Now, if you see this morphology, this twisting or various amplitude of a wide complex tachycardia, of course you're going to be thinking, number one, okay, prolonged QT, and it's triggered by electrolyte abnormalities or medications like antipsychotics, antiarrhythmics. However, we also have to think about that other subset of polymorphic VT, which is just typical VT. It's ischemic, right? They could be having an MI with it.
Sure.
So, of course, when you shock these patients, or if you convert them back into a sinus rhythm, you're going to immediately get that EKG to look for any ischemia, to look for patterns of STEMI. Because if you look at the EKG repeat and you see a normal QT, you should be thinking to yourself, okay, this is not an electrolyte or QT issue anymore.
Right.
I'm thinking more of an ischemia issue or underlying heart issue, which you have to go down a different path. You're getting troponins, you're doing the whole ischemia workup. Sweet.
Right.
So why don't you take it from here about how to spot it clinically and what you do treatment-wise?
So I'm going to get into that, and this is going to be one of those like, what does Kanye say? Hold up, wait a minute.
I'm going to let you finish.
I'm going to let you finish. But I think it's really important. We're talking about torsades here a little bit as well. Let's talk about some of the states that can cause torsades or like very low MAG, because we had a podcast episode on this. Do you remember by who? It was the great Dr. Mary Claire O'Brien,
the GOAT,
one of our mentors. Hashtag GOAT, hashtag we love you, hashtag MCOB. There you go. That's all you need to know. But Mary Claire O'Brien, right? Remember when she dropped it? She really talked about 3 states that you should really be thinking about it, right? So think about MAG, think about diuresis, right? So you really should be thinking about MAG in your patients with heart failure, right? These folks are set up to go into torsades. They already have heart failure. They're already on Lasix. They're already on medications that are going to deplete their MAG. That's why you should always order a MAG with your heart failure patients. Number 2, your alcoholics. Your alcoholics are losing a lot of fluid, ADH, all that good stuff. So think about MAG, checks on them as well, especially if you see any type, they're complaining of palpitations or you see something funny on the telemetry strips. And then lastly, like your really poor diabetics as well. They're going to be, having a lot of osmotic diuresis going on. So just in general, think about, patients in classes that are going to be losing a lot of fluid and going to be having low MAG. That's absolutely critical to think about, especially if somebody is, developing a pattern that looks like torsades. Does that make sense?
Yeah, of course. And the other 2 electrolytes, just for completeness sake, hypokalemia and hypocalcemia. It's easy to remember. All 3 major cardiac electrolytes, as I call them at work, calcium, potassium, magnesium, the 3 major cardiac electrolytes, all 3 of those being low will put the patient at risk for torsades, of course. And of course, the treatment, the immediate drug of choice in a stable patient and unstable patient is magnesium sulfate. That's even if the patient's magnesium levels are normal. This is so important. This is so important. You may have a MAG level back and you're like, well, I see torsades, but the MAG level is normal. Do I need to give MAG? The answer is yes. Now, the standard dose is 2 grams IV quickly. Now, you're going to meet some resistance with this. Sometimes you'll give that 2 grams, and obviously in the pharmacy order or maybe your EMR order will say this is over 30 minutes. And you're going to say, nope, you were giving that quickly, over 1 to 2 minutes. You're not doing the 30-minute infusion. Now, what is the biggest side effect of doing this? Of course, you have to be careful about the hypotension from magnesium. And these patients are very prone to hypotension because of their arrhythmia. So be very cautious, have IV fluids at the ready. And of course, what you should also have at the ready is your thumb. Your thumb. As if you're watching on the YouTube, you can see me wagging with my little thumb right here. Yeah. Yes, you have your thumb. Why is that? Because you are going to be using your thumb to press the synchronized cardioversion button.
or your index
or your index finger, for more control.
I'm an index finger type of guy.
Really? I don't know. I'm more dramatic sometimes. Okay. You know what I am.
Like a thumb.
Yeah.
I know you.
Yeah, you know how I am. I like to. Yeah.
Got it.
Yes, I'm like David Caruso in CSI Miami, brooding, always brooding.
Man, I love those intros. I will never forget watching those clips of the.
I watched it last week. I thought of you heavily. All right, let's keep going here. So magnesium, we know this stabilizes the cardiac membrane, even if the levels are normal. This is so important. Such a quick pearl here. That even if the levels are normal, you are replacing MAG. You are giving the 2 grams of MAG.
Right.
Now, let's carry it over to you here. Let me ask you a question.
Yeah.
Because it was in the stem, right? The patient's unstable. It goes right back to the ACLS algorithm, right?
Yeah.
So unstable patient, meaning they're either unresponsive or altered mental status, hypotensive, or obviously they're needing oxygen or something like that. I don't know. They're getting to a point where they are not behaving at room air.
They're not good.
What are you doing? Obviously.
Literally synchronized cardioversion.
Yeah, we're talking about cardioversion. That's what we're talking about.
We're talking about practice? Or you're talking about cardioversion? Oh,
I was hoping you picked that up.
I hope our Allen Iverson, fans are listening.
It's getting pretty old now. That was like more than almost 10 years ago.
We're talking about practice. We're talking about synchronized cardioversion, and repeat that over and over again. Exactly. Cannot emphasize that enough, though. We're talking about synchronized cardioversion. Please, please, please. Talking about synchronized cardioversion. So say you do synchronized cardioversion. What are you doing after that, Briggs?
Obviously, we're repleting the electrolytes, which you're doing at the same time. You're giving the magnesium, and if you're unsure, you have no labs back. You should probably just go ahead and give calcium, potassium if you want to, because you just don't know what's going on with this patient. Yeah. You should also be reviewing their med list. Hopefully you have done that already. If you haven't.
Sorry, that caveat, the potassium, obviously you're not doing it on a patient who you suspect might have hyper K and stuff like that, right?
Of course,
so,
yeah. But obviously if you're dealing with life-threatening torsades and you have a Chem 8 back, you're going from there.
Yeah.
Yeah, you're reviewing those meds. That doesn't help you at that very moment, of course. You can't take back what the patient has already taken, probably. Sure. But stopping any meds and preventing that from being given in the near future while they're in the ED would probably be very helpful. So while they're in the ED, if you shock them, bring them back, and they start vomiting, you probably shouldn't give them Reglan. you probably shouldn't give them.
Maybe don't give them 80 or 120 Lasix, right?
Yes, exactly. You shouldn't be putting them right back in that position that got them there in that case. So.
Yeah. Hey, so let's do one for the shorts, right? They love the shorts. So you've got a patient with polymorphic ventricular tachycardia. It looks like torsades. On your evaluation, they're starting to become a bit altered. They're not following commands for you anymore. However, their blood pressure is okay. It's maybe on the lower side, maybe 90, 100 systolic. What's the most appropriate initial treatment for this patient?
Definitely still cardioverting them.
So you're still cardioverting. So you're not going to MAG right away, right?
Yep.
Why?
Because they're unstable.
There you go. Done. Remember, always remember, even if it looks like torsades, number one thing, if they've got ultramental status, they've got signs of end organ just dysfunction going on, they're unstable, you need to just go ahead and synchronize cardioversion. Yeah,
and this is so common because, the board test is always going to give you a scenario like this. They're never going to just straight up say they're now hypotensive. What a bunny question, okay, they're
Everyone
hypotensive.
Knows what to do.
Of course you're going to shock them. Yeah. Everyone, every time I've asked a resident or student that at work, they're like, of course I'm going to shock them. It's just a trick question.
Right.
But the real trick question, the boards are going to trip you up, is that ultramental status patient. And another caveat, a correlation with this would be the patient who's bradycardic. And they always love giving that example of they're like in their 70s and they're bradycardic and now they're altered. Well, the answer is always to pace them. You're going to start pacing them. You're going to hang your IV, epi drip, that kind of thing. But it's the same correlation of unstable patient. You're giving electricity to them with an unstable arrhythmia or unstable rhythm of some type.
Hey, so let's do the recap and then we're done.
Let's do it. So torsades is a form of polymorphic VT. There's also ischemic polymorphic VT, which is treated the same as monomorphic VT, which is look for ACS, get an EKG immediately after shocking them. And if their QT is normal, then you need to immediately think about ischemia as their cause. Right. The treatment first line of torsades, though, of course, is magnesium sulfate, 2 grams, rapid IV push over 2 minutes. You're not waiting 30 minutes for that to go in. But if they're unstable at any point, change in mental status, hypotension, needing oxygen therapy, breathing abnormally, whatever, you're shocking them immediately. We didn't really go over choice A, which was, I thought, pretty obvious, not to intubate this patient. That would kill them.
Oh, my gosh. That's a great point.
Don't do that. I didn't really cover it because I thought it'd be straightforward. But choice B, amiodarone, was also wrong. That's not a good medication to give in someone because it can prolong the QT, of course. And that antiarrhythmics in general don't treat torsades at all. They can make it 10 times worse. Most antiarrhythmics cause prolonged QT. So in this case, we are addressing the electrolytes, addressing the underlying cause.
Yeah, and that's great to know because you might have that patient where they're now in torsades, they're getting like this, and if you look at the medications they got right before that, like 120 of Lasix and amio is what they got before that, right? Yeah. That is not some... I might be speaking from experience here, but so just remember that.
We live and learn, Dr. Hussein. We live and learn. But,
hey, sometimes you're boarding patients and you're waiting for them to get admitted.
Yeah, exactly. So, dealing with the consequences.
That's the inpatient team managing it, but you can always step into the rescue and you know what to do.
Exactly. All right. I think that's it.
I think that's it, man. It's good to be back, Briggs.
Good to be back.
See you, man.